Now, the endometrium dysfunctional uterine bleeding leading to endometrial curetting is one of the bread and butter in investigations in any lab which is doing histopathology. And now the diagnostic curettage and biopsy which is done, the timing for this has to be very carefully selected. For if the patient is suffering from infertility or sterility, the sample has to be taken in a premenstrual, just before menstruation, so that any defects related to ovulation, etc., they can be seen or detected. All cases with where the cause of bleeding per vaginum is not known, then it should be done immediately without any delay. We are suspecting carcinoma on pap smear or otherwise, then based on ultrasound finding, it has to be done without any delay. In post-abortion bleeding also, it needs to be done without any delay. Now, quite often the material we get in these samples, quite often it is mixed with blood or mucus, and it is important that we, before processing the tissue, we take the blood clots properly, remove the blood clots properly, and for this it will be nice if we float the sample in tap water in a petri dish. The clots will float, and then process the tissue and clots separately. Don't throw away the clots. Sometimes some cells, they are seen in the clots as well. If they feel that the tissue contains a lot of mucus, then rub it to a rough filter paper or gauze. And what is adequate biopsy? This question is difficult to answer. I mean, we are, especially in private practice, we have to accept all samples. However, some basic rules: if the tall columnar lining on the surface can be seen in the biopsy, we can consider that it can be taken as adequate. It must contain some good functioning glands and stroma, and if we are thinking of tuberculosis, then some well-formed tubercles with caseation should be there, depending upon the history. Like, see, this is slide in which there is the lining can be seen. There are some adequate glands, and there is some stroma can also be seen. Now, there are sometimes some problems which we deal with quite often. Sometimes there is inadequate clinical data provided by the clinician, which is a very common problem, especially in most of Indian hospitals, because this clinical data uh, helps us to correlate with the dating, with the disease profile, and this can really cause big problem. Sometimes the curettage is done at the wrong time, and there are insufficient curettings. Like, we give an example. We think that the history in this case was not provided initially, and we thought that this case is of a proliferative phase, whereas it was found that this sample was taken on 27th day, and as a result it turned out to be an anovulatory cycle, and the diagnosis was changed as a result. Now, in this case, if we see that there are a lot of vacuoles below the glands, and this sample was also taken on the 25th day. So thus, this means that the diagnosis in this case again had to be changed to luteal phase insufficiency, and so history is very important. Now, there are some causes related to the pathologist. Quite often pathologists are not very experienced, especially when they have just entered this profession. There is improper preparation of the material, problems in processing, etc., and there are problems in the prepared microscopic sections. Again, this is more related to our technicians. Our staining may be adequate, anything can happen, and it also depends upon the recently read literature. So whatever the pathologist has read recently, or he has attended some webinar or some conference, then whatever he has heard last night or then he tries to make that diagnosis, thinks of that diagnosis more of then causes related to endometrial tissue. There is a difference in appearance in different regions. This could be cause of some hormonal imbalance. Now here if we see, the basal endometrium is different from the endometrium at the which is more superficial. The glands, they are more coiled, and here the glands are more tubular. So such problems do occur. Ideally we should, if we find such case, the most developed area should be taken as the right face. Then if we take a sample from the isthmic endometrium, normally we find in avascular mucosa flattened slit-like glands and dense stroma. Now this area is usually considered unsuitable for functional diagnosis because it fails to undergo regular changes in the cycle, and it can be wrongly interpreted as atrophic or deficient. So the gynecologist, we just tell the gynecologist to repeat the biopsy or the curettage because the sample is not adequate. Now this is the isthmic endometrium, and here if we see, there is a lot of edema along with some glands, and it is difficult. The different areas show different types of glands and very little stroma is there, so better to repeat. Now sometimes the endometrial tissue may show changes in morphology which lag behind the changes in the function. For example, the effects of ovulation are histologically evident only after 36 hours. So if on ultrasound or you feel that the ovulation has already taken place, some other tests, Fern tests, etc. have been done, then the effects of ovulation are histologically evident only after 36 hours, or there may be functional changes may not lead to detectable morphological changes. That is also sometimes seen, so we should correlate with other findings. So sometimes there are problems of estrogen and progesterone receptors which may different at different sites in the endometrium, and they also affect a menstrual cycle. So ideally we must take the endometrium from fundus, that is the functionalis, for diagnosis of any hormonal imbalance. From the Salis area, it is better seen in carcinoma or its precursors, hyperplasia, and irregular shedding of endometrium. Now, effects of hormones. The various hormones which could be exogenous or endogenous are the same as of the normal hormones secreted by the human body. And firstly, let us take up the effects of estrogen. Minute amounts of estrogen are very potent and capable of producing rapid and significant changes in the target cells. So for this reason, it is very important that the history of uh, hormones is made available while taking the biopsy. As a result of estrogen, the cells enlarge and grow longer, and the stromal cells, they proliferate, and the endometrium increases in height. Now, the more the endometrium grows, the more the estrogen the ovaries secrete, and as a result, these changes are also the effects of once progesteronic phase starts, these changes stop. Now these days, ladies take the progesterone only pills. So for progesterone effects to take place, there is a need for and some pre-exposure to estrogen, and the first changes are seen only after 36 hours. And there is clearing of the nuclei of glandular and stromal cells with glycogen granules in the cytoplasm at the base of the cells. As a result, the mitotic activity ceases, which is a hallmark of estrogenic phase. The glandular cells, they differentiate, and the spiral arterioles, they begin to grow, and just as around the blood vessels, the cuff formation by the fibrous tissue, it all starts appearing, and the stroma differentiates into large polyhedral decidual cells or in smaller endometrial granulocytes. Now, in a case of dysfunctional uterine bleeding, once we know the basic effects of the hormones, we can now move towards the dysfunctional uterine bleeding, uh, which is defined as that state of abnormal uterine bleeding without any clinically detectable organic pelvic pathology like tumor, inflammation, or pregnancy. The bleeding may be abnormal in frequency, amount, or duration, or a combination of all three. So the endometrium is the most important target organ for ovarian hormones, and any absent, deficient, or excessive functions of ovarian cells produce different morphological changes in the endometrium. So it is good to have an ultrasound also if available, and our current concepts conclude that the most likely cause is due to local causes, and there could be some disturbance of the endometrial blood vessels and capillaries and coagulation of blood in and around these vessels. It could also be related to the alteration in the ratio of endometrial prostaglandins, which are delicately balanced in hemostasis of the menstruation. The endometrial abnormality may be primary or secondary to incoordination in the hypothalamic pituitary ovarian axis. I mean, right from the pituitary, the secretions of the hormones may be affected, which may lead to secondary changes in the ovary and then further into the endometrium. The emotional influences, worries, anxieties, sexual problems also cause problems in the hormonal imbalance, and so that is why dysfunctional uterine bleeding is grouped into ovular and non-ovular groups. And in majority of the cases, endometrium is in the normal secretory phase. In 30% cases, it is hyperplastic, and in remaining, it shows irregular shedding, irregular ripening, and atrophic pattern. So based on this, we must correlate it with the phase. The dating becomes important. The important causes of dysfunctional uterine bleeding are paucity of estrogen or excess of estrogen. There can be an abnormality of the progesterone secretion following ovulation, or there can be an abnormality in the proportion of estrogen and progesterone relative to each other. So the entire interplay of these hormones, less estrogen, excess estrogen, abnormal progesterone, and their uh, relative to each other, amount to each other, can cause different patterns in the uh, endometrium. The in cases of infertile cases, could be abnormal endometrium, there could be inflammations, chronic endometritis, hormonal imbalance, ovarian dysfunction. The ovary may be secreting certain hormones which can lead to different patterns leading from either atrophy or hyperplasia, and many of the histopathological abnormalities of uh, dysfunctional uterine bleeding and infertility are the same, and we will consider these abnormalities. Now, there is algorithmic approach. The we can have certain common steps. First step is try to date the endometrium. If successful and if it correlates with history, the problem of histological diagnosis is over. That is, endometrium is normal and structure and function. Then the cause of infertility or could be somewhere else. Our diagnosis is problem is over. If dating is not possible, then try to classify the lesion in one of the following groups: hormonal imbalance, inflammation, hyperplasia, or malignancy. These are the four commonest causes, and this is where our diagnosis will fluctuate. Now, first we take up the hormonal imbalance group. Look at the glands. They could be small and circular, narrow, normal sized, or dilated, and look at their lining cells and their activity. Now, after looking at the gland, whether they're tubular, or look at the stroma. It could be like proliferative phase or with lot of mitotic figures and some edema. It could be like secretory phase with again compact edema, or depending upon which phase there is some formation of decidualization or any other character. If there is paucity of estrogen, uh, especially in the absence of ovarian hormones in childbearing period, we find that there is no hormonal stimulus and the endometrium is in resting phase. And if continued, the glands and stroma, they gradually atrophy and they are slowly absorbed. The narrow glands lined by the cuboidal epithelium, small nuclei are seen if the paucity of estrogen continues. The cytoplasm is quite often scanty, and stroma contains normal densely packed spindly cells. It is important that you see this presentation along with the dating of the endometrium, which I have earlier sent. For revision, see both of them together. Now, in this we see there is a deficient proliferative phase, and a lot of the glands are very scanty, and in the stroma is again shows lot of there's no very little cellularity. Some glands are in the coiled, some are tubular, and the number of cells is generally less. When there is a persistent estrogenic deficiency, uh, we have to correlate it with the phase of the uh, of life, which is possible if there is puberty or menopause, then there is a deficiency of estrogen naturally. Otherwise, or if the ovaries have been removed, there we can see the persistent estrogenic atrophy or deficiency. Now, supposing there is excess of estrogen, then because the lady has not ovulated, and as a result the progesteronic phase has not started. So why could this be? The luteinizing hormone fails to rise, and uh, after the follicle has matured, and as a result the follicle will not ovulate. There sometimes there is no leading follicle is selected because of the abnormal oocytes or insufficient follicle stimulation hormone stimulation, and as a result the follicle persists. There could be any anovulatory cycle, and this may occur normally at the beginning or end of the childbearing period, and is one of the very common causes of infertility, and three types of ovulatory cycle have been described. Type A, the follicle continues to secrete for about 7 to 10 days and there is persistent follicle leading to irregular proliferation. Type B is additional secretion of luteinizing hormone which takes place with the very little luteinization of the follicle resulting in abortive secretions. Type C could be when the follicle becomes insufficient very early and the estrogen levels also remain low as a result, and there is insufficient follicle resulting in deficient proliferation. Now, depending upon the time interval, all changes from atrophy to hyperplasia can be seen, whether there is how long it takes, whether there is excess of estrogen which is continuing, and or the estrogen levels fall. Accordingly, there could be atrophy or hyperplasia, etc. Now, the first half of the cycle differs very little from the proliferative phase of the normal cycle. The main diagnostic proof whether there is something abnormal lies in the absence of secretory changes in the second half of the cycle. That is, whether proper ovulation has taken place, not taken place, which changes the hormonal profile to progesteronic phase, and accordingly there are changes. Now, for all practical and therapeutic advantages, the ovulatory cycle is divided into two histological types, that is deficient proliferation and irregular proliferation. Okay, now slide of deficient proliferative phase. Again, if we see, the number of glands is very less, very little mitotic activity can be seen. Now, irregular proliferation, there is a growth of glands in stroma which clearly exceeds normal proliferative phase, and the glands vary in distribution and they are closely packed or widely distributed, and the diameters differ considerably. The lining is single or multi-layered. Irregular proliferation is caused by deficient follicle, and this secretes excessive estrogen or androgen, which is then metabolized to estrogen in fat tissue. This causes the direct precursor due to direct precursor of glandular cystic hyperplasia, and there can be withdrawal bleeding due to reduction in the estrogen level. Patient sometimes has taken some hormones and this ovarian problem is there, and this is the number of glands is markedly increased. There is prolonged proliferation even in the second half of the cycle, and you can see in the stroma also there is marked proliferation. And see, the glands, they become high, the number of glands, they lie back to back. This is another slide of irregular proliferation. The stroma is dense and the glands, they are again lying back to back and they are quite irregular. Now, the glandular cystic hyperplasia, this results as a consequence of the persistent follicle that has maintained high levels of estrogen for a long period of time, and there are repeated ovulatory cycles with the persistence of follicles, as in polycystic ovarian disease, which may be there. It could be because of the repeated follicular atresia with theca cell hyperplasia, and occasionally there could be prolonged excessive estrogen therapy. The glandular cystic hyperplasia could be because of it is one of the commonest type of homologous hyperplasia, in which the glands and the stroma they proliferate concurrently, and we get a dense stroma and along with the numerous glands. Now it is sometimes we also get the heterologous variant when we get the interstitial or the glandular type of hyperplasias. Now, luteal phase insufficiency is an important cause of dysfunctional uterine bleeding, which can be preceded by a normal, short, or inadequate follicular phase, and this may result in the delay in the progesteronic secretion, and the progesterone secretion may fall below the physiological levels, and a gradual rise in progesterone level may take place instead of a rapid rise, and this may lead to the inadequate luteal phase. A premature decline in the progesterone levels may also take place, leading to a short secretory phase, and very quickly there could be menstruation, or the all the changes related to a progesteronic phase may not take place properly. The corpus luteum may persist sometimes for more than 14 days, and there could be a relative deficiency of the progesteronic phase associated with hyperestrogenism. Now, this is a slide of luteal phase deficiency. If you see the stroma, it is inadequate, and also the glands which have been formed, they do not have, they are quite inadequate. The nuclei are still in the basal region, and there is incoordinated, they, they could be incoordinated or coordinated delay in the maturation of the glands and the stroma. From the 18th day to 25th day of the cycle, gradually the stroma develops, and along with that the glands they they start secreting, and we can only identify all these changes when we correlate the histology with the history of the patient. Now here if you see the luteal phase, in the glands still the nuclei are at the basal region, and the stroma is also still quite compact, and there is when sometimes the progesteronic secretion following the ovulation gets delayed, or there could be rise in the progesterone which is quite slow or inadequate, and this leads to the changes which normally takes place in the progesteronic phases. They are very slow or inadequate, and sometimes there could be a dissociated delay, and this because of this there is the estrogen deficiency is there could be the estrogen deficiency is there, and the endometrium does not grow properly in the estrogenic phase, and the glands are quite sparse, straight and narrow. There is no spiral formation, and the stroma is also very poorly developed. So when estrogen is not there, the luteal phase also becomes inadequate. And here if we see that the glands are there, The stroma is very little edema, and the, there are hardly any glands formed. Here also there is the vacuoles are still at the base. They have not started secreting. In There is a delay. The stroma here is edematous. The compact phase has not started, and this results in the luteal phase is insufficiency with the associated delay. There is dissociation of development between glands and the stroma. They, depending upon the date, they are out of phase. The glands that develop along a different timeline, whereas stroma develops along a different timeline. And we see if we look in the adjacent glands, uh, the spiral arterioles, they could be normal, or sometimes the gland are in uh, the vacuoles have still not secreted while decidualization has already started taking place. And sometimes there is inadequate secretory phase due to luteal phase insufficiency associated with the estrogen deficiency. The endometrium is poorly grown, the glands are sparse, straight, narrow, and undistended. The secretions are scanty. Now, if we see here, there is inadequate secretory phase. The glands, uh, there is some stroma, there is some edema, but in the uh, stroma, and the compactness has not coming. The glands, uh, again, they are inadequate. They have hardly developed. This glandular stromal asynchronicity, there is a preceding estrogenic levels. If they are normal, then luteal insufficiency is delayed, and there is poor secretory transformation and irregular ripening. Sometimes there is premature failure of the corpus luteum, which leads to a short luteal phase, and there is focal interstitial hemorrhages can be seen, and crumpling with other features of the luteal phase deficiency. I mean, the luteal phase, which normally leads to formation of hemorrhages at the end, all this starts quite early. Sometimes there is secretory hyperplasia, especially in the pre-climactic period, due to excess production of the hormones in the hypophysis. The entire hormonal axis from the brain, it is affected, and there is, as a result, there is hyperfunction of the corpus luteum. Now, this is the secretory hyperplasia. The glands, they are proliferated, and they are quite lying back to back. Sometimes there is irregular shedding, and there is a confusing histological appearance, and this results in a mixture of fragments of endometrium in various stages of regression and dissociation, and many days after the start of the menstruation. And the shedding continues for many days, and the corpus luteum may develop normally, but it may fail to regress at the proper time, and then continues to secrete progesterone even during the menstruation phase, and causing there is a mess in the uh, estrogenic, in the hormonal cycle, and there is irregular shedding. Now, this is the irregular shedding. Even during the menstrual phase, or even after that, there is the progesteronic phase continues, and irregular bleeding keeps on continuing during the entire menstrual cycle. Area stellar reaction, you have all done assignment on this. The paper was sent, and which is basically enlarged granular cells with enlarged nuclei and unusually clear cytoplasm. This can sometimes be confused with the carcinomas, and especially the clear cell carcinoma, and this may be due to accumulated gonadotrophins, which may be secreted after abortion, or the placenta continues to secrete gonadotrophins. Now this is the uh, area stellar reaction. The cells, you can see, they have got a clear cytoplasm. There is proliferation. A hobnails, this is known as hobnail appearance. Hobnails which are used to in the grounds, they are fitted, and in the olden days they used to be hobnails used to be uh, fitted in the horses or in the, and so this is the area stellar slide of area stellar reaction. So this the if we summarize the hormonal lesions, there could be small circular, if the glands are small, circular and narrow, and then if the stroma is dense, it could be atrophy or deficient progesteronic phase, or if the stroma is loose, then it could be atrophy or progesteronic atrophy. And if the glands are normal, and they are normal in number, and the normal progesteronic phase is there, it could be, and it is continuing, it could be an ovulatory cycle. If the number of glands is increased, then it could be repeatedly an ovulatory cycle with hyperplasia, and the estrogenic phase could be proliferative or secretory. And if the glands are enlarged, dilated, and cystic, it could be hyperplasia or other abnormal hormonal imbalances. I think it is okay. We have 5 minutes more. Sometimes the iatrogenic effects of are also could be there due to oral contraceptives and other hormonal therapy, which affect the uh, endometrial pathology. There could be physiological effects of the low doses uh, of various hormones and different reactions to higher doses. The estrogen therapy prolongs the proliferative phase and suppresses the secretion of follicle stimulating hormone and inhibits the development of corpus luteum. We have all known that how especially in older days, the oral contraception used to be done. The endometrial hyperplasia after prolonged use of estrogen could be seen, and estrogen therapy is given for relief of menstrual menopausal symptoms, as therapy for carcinoma breast, and for management of hypogonadal conditions. Tamoxifen these days is given for the tumors which competes for the estrogenic sites and has anti-estrogenic properties in post-menopausal women. It induces estrogenic-like effects, and it with tamoxifen we can see changes from just multilayering to hyperplasia, or even carcinomas can develop. In some patients, multiple or large endometrial polyps may also be developed. Now, the progesteronic therapy is used for management of dysfunctional uterine bleeding, for endometriosis, for endometrial hyperplasia, and even sometimes endometrial carcinoma. And this shows in the pathology as well. And this therapy depresses the follicular maturation and prevents ovulation. And we get after 4 weeks of therapy, we get a picture of arrested proliferation, and after about 12 weeks, we get arrested secretion and decidualization with atrophy of glands. See, this is a slide of the progesteronic atrophy. There is marked this compact stroma, and the glands, they are irregular. Intrauterine contraceptive device is a very common copper coated plastic device which is sometimes used for contraception, and this is impregnated with the progesterone, and especially if the history of this is there, it helps in the diagnosis. And these ladies have intermenstrual spotting, menorrhagia or irregular bleeding with pelvic pain and vaginal discharge. The endometrial biopsy sometimes may be needed to confirm or refute the diagnosis or to the presence of endometritis. And inflammation related to intrauterine corpus device is limited only to superficial endometrium without any diffuse involvement.